then they would do a lot better with it. So cognitive slowing is a big one. Weight loss, there's actually a weight loss drug with determined Tomax in it, and I think it just reduces their appetite a little bit. This is not a magic for all, but for weight loss, but some may lose a few pounds. I don't like using Tomax in very cachectic or anorexic patient. I probably would avoid it. If they're barely having trouble holding on to the weight they got, then we don't want to use it, but that doesn't seem to be an issue for most patients. Seizures in hands and feet, so they're going to have tingling in fingers, nose, and toes, and if I start them on Tomax, I will tell them about this, because if I don't, I know when they're going to call the office and go, my fingers are tingling, my toes are tingling, what's going on? And the higher the dose, the more likely that to happen. With 100 milligrams, I don't see that very much. Sometimes I would. And then again, 100 milligrams is what I use for migraine prophylaxis. I have them, I prescribe, if they have to be on it, and they can tolerate a little bit of tingling, then I just give them potassium. I prescribe potassium. Or I can have them eat a banana a day, or 2 bananas a day, and get them up. So this can cause a very low dose of clinically low potassium, enough to get them to tingling, not much to pick up on blood work. They get more potassium in them, this seems to improve. And it's not dangerous. It's not going to damage their nerves or cause any issues. If they can tolerate a little bit of it, that's fine. Kidney stones, I don't use it in the patient that has history of kidney stones. Huge risk of another one. During Tomax, I tell them to be very well hydrated. Risks of birth defects, and in the patient with migraines, I avoid it if there's a risk of them getting pregnant, and I can't trust them not to get pregnant. I will not prescribe this. In seizure patients, it may be a bit more complicated, and I have had few that got pregnant that had healthy pregnancies, but you always have that, phone call, so-and-so's pregnant, and you go, what are they on? So this is one of those heart drop stuff moments if they're on Tomax. By the time they find out they're pregnant, most of the damage has been done. So you can stop, but the risk of neural tube defect is high. And so as you guys learn some of the embryology of what forms when, you can see by 6 weeks a lot of damage can be done already. And then in female patients who take oral birth control, it can actually reduce efficacy of the pill, so it can put them at risk to get pregnant. So this was done in a study with valproic acid as well, so in combination of, and I think that most of the patients are most likely fine, although you may have a pharmacist call your office and, do you know that they're on Tomax and birth control only? And what I do in this case is I just tell them, especially for late patients, I just say, call your OBGYN. I haven't prescribed birth control in years. There's many new ones out. Call your OBGYN, tell them you're going to be on Tomax so that they can see if the birth control you are on is appropriate. Some of those low estrogen and low estrogen, low progesterone, maybe such a low dosage of hormones that may actually decrease their efficacy. So, and I had a couple patients that stay on their birth control. I had a couple that went on a depot shot. I had one that got an IUD because she didn't want to risk it. So they just need to discuss this with their OBGYN, and then you've documented this, and you've talked to them about this, and then I'll ask them, what did your OBGYN say? I didn't talk. You got it. And then if they don't talk, I'll call OBGYN myself and say, okay, what are they on? And is it okay for them to be on this? Lamotrigine is a very effective drug, marvelous side effects, and monotherapy is one of the lowest risks of tetragenicity, still a little bit of risk of cleft palate. But number one thing with this patient is the highest, very high rate of Stevens-Johnson syndrome, 1 in 4,000, and that's pretty high. So, and this will kill a patient. They're going to be in the burn unit. So when this does happen, it's pretty dangerous. So you're going to be monitoring for any rash, and I tell patients, if you get any rash when you start this, call my office. You don't need to call them back figuring out where is the rash happening, did you eat anything funny, or allergic to any foods, is it your new deodorant, did you have new detergent? You just stop it, you stop the medicine, because it's risky. If they complain of any rash whatsoever, discontinue this medicine immediately. And the rash usually is going to occur within the first 6 weeks. So if they've been on this stable for years and they got a little rash, that's probably something else. They're not going to, it's unlikely they're getting a symptoms. And this is also more common for patients who are also on Depakote, and even higher if they're on Depakote and Lamictal. So with the lamotrigine, the important thing to remember is rash and risk of Stevens-Johnson, if anything that you're going to remember from the slide. And it's also titrated very slowly per manufacturer. The manufacturer is going to have information on how to start this drug, what dose, and how to titrate it based on what type of seizure they have. Keppra is a great drug. I mentioned that before. Very low risk of tetragenicity. You don't get the Stevens-Johnson. You don't have the. You can use it with liver toxicity, although you may want to use a lower dose with renally excreted. Very low drug-to-drug interaction. I started with 250 BID just to start them, and then I go up to 500 BID. This is not a therapeutic level of the, this is not enough medicine to control their seizures. I don't care how thin your adult is. 500 milligrams BID minimum, and some will go up to all the way up to 500 BID. And once they maxed out, then I add another seizure medicine. They're still not controlled. The one thing to mention with Keppra though is something that we didn't talk about with any other medicine, and this is specific to that, is if your patient has many psychiatric issues in the past on multiple psych meds, I would bring up to them that if they have any significant changes in their mood, that they need to call me and let me know, and also talk to their psychiatrist. Any thoughts of any suicidal thoughts, any homicidal thoughts, any irritability, anger issues. So this is something that probably, I don't see that very often, but I've had a patient that developed severe depression when she started Keppra. When we stopped it, she was fine. And so most of all the other hundreds of patients I see do great with it. So that's something to keep in mind for. Vimpat is a great drug. I'm not sure I'm not going too late. And it is one of the newer ones that came out. This is, if you go way back under your status epilepticus chart, this is your second line agent. It does come in IV, so you can use that. And then you can use IV as well as PO doses equivalent. This is expensive drug. It's a newer drug. It's expensive drug. If I had seizures, I probably would want to be on this or Keppra, but Keppra is cheaper than this, so that may be an issue. Rapid onset, you don't need to monitor liver function, bone marrow, you don't need blood work. And also, looking back at your slide, if you see risk of hepatotoxicity or anemia on any of the side effects or long-term effects under your medications, that means either the patients that are going to be getting blood work every 6 months to check their CBC and CFB, you're going to be monitoring their hepatic function and their blood counts. Vimpat and Keppra, you don't need to do that. Topmax, you don't need to do that. So it's good. They don't need blood work every 6 months. So with the diagnosis of seizures, once you make the diagnosis of epilepsy, you started them on medications. It can be life-changing or it can be a nuisance. So your airline pilot, your scuba instructor, your chauffeur, someone that drives for a living, your truck drivers, this is going to be tough. Some jobs will let them drive if they're stable on seizure medications. Pilot, their career is probably over. So if the American Academy of Neurology recommends that patients are not to drive, swim alone, or climb heights until seizure-free for 6 months. And some of those very poorly, difficult to control patients that still have breakthrough seizure in spite of being on 2-3 meds, especially the tonic-clonic ones. Some of them I tell them not to take bath by themselves, that there's someone in there with them, or take a shower seated and things like that. But for 6 months, after 6 months, the risk of seizure goes down significantly enough. So if they just had a 1 seizure, you didn't start them on meds, after 6 months, the likelihood of them having another seizure is pretty low, especially if it was 1 provoked seizure. But if they had a seizure, 2 EEGs abnormal, whatever the reason, stroke patients, whatever the cause of their seizure that you found, you started them on anti-epileptic drugs. They may have had a 2 or 3 breakthrough seizures initially as you were titrating doses, figuring out what medications worked for them here and there, and then they were stable, have not had a seizure in 6 months. They're taking their meds, they're not forgetting their meds, they're taking it correctly, they're very compliant. After 6 months, the risk of breakthrough seizure goes down significantly. So you may have seizure, the patients that have been stable and have not had a seizure in 10, 20, 30, 40 years. So it's in the state of Oklahoma, it is patients' responsibility to report themselves, and the Department of Transportation is going to temporarily revoke their license for 6 months. And then you're gonna get paperwork to fill out. You can get lots of those if you treat seizures. Once a year for every patient, where you're gonna, and all you're gonna say on there is what patient is on, when was the last time that they had a seizure, and then the Department of Public Safety can determine if it's been 6 months, they're stable, you mark that they're stable, they haven't had any other issues, they'll give them their license back, and it's their job to do that. So I tell patients, on pay. But again, if they have, I had a non-compliant patient. Tuberous sclerosis is a neurological disorder that puts you at risk for seizure disorder. Most of these patients have seizures as well, so they can't ever come off their medications. And I had a patient with tuberous sclerosis that have been non-compliant for years and years and years, and he didn't report himself when he had seizures, and he was in a motor vehicle accident that nearly paralyzed him from waist down. And now I see him every 6 months, takes his medications, comes in, and non-compliance is over, but it took him nearly dying before he did that. So. Sudden unexpected death in epilepsy, and I discuss this with patients, especially ones that have a hard time with the concept of, I just had 2 seizures, why do I need to be on this medication for the rest of my life? Maybe I'm not going to have another one. Is there a chance I'm going to have another one? I don't have a crystal ball. You may never have another one, or you may have another one. But it's not just the risk. Of course, there's a risk of status epilepticus and all the issues associated with them dying, brain death from going into status. But also, if they have uncontrolled seizures, frequent seizures, then they're at risk for sudden unexpected death in epilepsy. So this is non-traumatic, non-drowning related death in people with epilepsy, and may or may not be associated with recent seizure, and it's not due to status epilepticus. So this is not that they fell and hit their head, or that they drowned it, or they climbed heights. So all of those are out, and it's not status. So it's everything in between. The patient just died in his sleep because he's got uncontrolled seizures. So they are at higher risk for this, and it's important to go over this. Just because you feel fine, you haven't had seizure in quite some time, get off your medication. And just because it's nocturnal seizures and you don't feel them, you wake up and you feel fine, and you think, well, I don't need medications, never affects me during the day, but what about this? So recurrent ongoing seizures is the strongest risk factor. And so again, the risk factors, the longer they had it, if they have frequent generalized tonic-clonic seizures, if the seizures go for a long time, and also a patient with IQ less than 70 with major neurologic insults such as stroke or head trauma. So these patients need to be monitored closely. And to lower risk of this, you prevent seizures from occurring. You treat these patients. So questions you may get as you, especially when you first diagnose a patient and you start them on medication. So can I drive? We've already discussed that, not for 6 months. And you're gonna get a lot of temper tantrums and pouty eyes and, but I'm gonna lose my job, I'm gonna do this, I'm gonna do this. But you can kill somebody, or yourself or somebody. What about alcohol? They can, unless they have a seizure disorder that specifically, alcohol is specific to them to lower their seizure threshold. Most patients are fine. And of course, this is in moderation. And what probably most of us think is moderation is not what medicine thinks moderation is. Half a glass of wine ever so often. So your alcoholics are at risk. So, I tell them very little. And then I also ask, if they start asking me what about alcohol, I ask them, well, how much do you drink? Because everyone's definition of how much they drink is different. And if what they're telling me sounds like quite a bit, 1 drink a day, and what's in your drink? How much of it? Or beer every day? Well, how much? A pack, 2 pack, 1 beer? One pack or 1 beer? Is it different? Is it just gonna put 1 on it, right? So find out and talk to them, and some alcohol, they're gonna be okay, a lot of alcohol not. What about stress? Emotional stress is not gonna cause them to have seizures. But if they're going through an emotional stress and they're not sleeping and they're stressed out and it causes them to be sleep deprived, then this patient is at risk. So I talk to them, if you're going through stress, you make sure you take care of yourself. You don't overdo it on alcohol. You sleep, you get plenty of sleep, eat healthy, you stay healthy, take care of yourself, and you're not going to have a breakthrough seizure because you're going through major stress. How long do you take this medication? I think I went over that quite a few times. You may do a trial to discontinue up to 2 years. And if they have if you have an idiopathic, provoked or unprovoked with normal brain scans, fairly healthy patient, and normal EEG, and if they have a breakthrough seizure, then they're going to need to stay on their medications. We've talked about birth control. The best pregnancy is with if the patient hasn't had seizure in a long time and they only had one and they've never been on med. The second best pregnancy is in the seizure patient, especially epilepsy, is pre-planned pregnancy. So this is something that they just going to need to plan this. Breastfeeding, and I've done some research on that because I do have patients asking me, if it was me personally, I think I wouldn't do it. Because from all the research that I've seen, there's still some small concentration of certain medications that can be in the breast milk, and you don't want the baby to have the withdrawals. But there may be a cost issue, they may be on a really low dose, and it may be one of this anti-seizure meds that's very low excreted in the milk, super low, and they can't afford formula, then they may choose to breastfeed. And you're not going to be the main one that's going to be making that decision. We're talking to their OBGYN, and we're talking to their pediatrician, and so forth. So will my children inherit this? Most of the seizures I see in the clinic are idiopathic. I mean, there's no family history, it just happened, and they developed a seizure problem, and I can't find a cause of this. And it's very hard for patients to comprehend. And most of those patients will not pass that on, but it can be genetic. And again, I don't have a crystal ball, and I'm not sure if you can pass it on to your children, probably not. But there are some neurological conditions that are highly genetic, and seizure comes with that neurological problem or that genetic abnormalities. Yeah, then they will pass it on. So questions your patients won't ask is, we've talked about sometimes unexpected death, epilepsy, osteoporosis. looking at this chronic toxicity. You're gonna need to document that you've discussed this, if your patients are on these two drugs, you've discussed this in their chart, and if they refuse to change to something different, or you choose to keep them on these, they've been stable in the breakthrough years, and your fear of a breakthrough seizure, you need to document, and they need to be monitored for this as well, if they've been on these for years and years. We've discussed risks of breakthrough seizures and seizure surgery. So these are the patients that have refractory seizures that are not responding to very well to medications or multiple meds, and they keep having breakthrough seizure. And this is a referral to a specialty center where these patients are going to have brain surgery in attempt to stop their seizures. They may have also a vagus nerve stimulator implanted also that can be effective. And I did not going to go into that. But again, that's I want you to know that that's an option. What do you do when nothing else works and a patient who's having seizures? You refer them for a surgery consultation. I think that's it. Any questions? I stood for so long. I know. Well, there's my email. So if you guys think of some